Good morning, everybody. We're going to start right now. The students, each of our graduating residents is required to present a grand round as part of their last year's requirements. And so Pam Francis is finishing. She started her year a little bit off cycle, so she's finishing pretty soon. And so this is her grand round. And so Pam's going to talk to us about bridging the communication gap. And so let's get started, Pam.
Good morning. Morning. So the title of my grand round is breaking it down, bridging the communication gap between physicians and patients. And this is something that I've been really, this is something I found that was very important to me, even from first year. And one of my examples of a case that I had as a second year was a mom that brought her kid in for a follow-up appointment for ADHD evaluation. On the first appointment, she brought him in. They had given her a children's center packet, and they left, supposed to fill it out, take it to the children's center, and return 2 months later. And when she came back the second time, she still hadn't filled it out. And so just in speaking to her and just kind of getting a feel for what was going on, the reason why she said she didn't do it was because she lost some of the pages. And we know those things are stapled so well. So I just I left out, I discussed it with my staff. I went back in and I asked her, I said, I'm not trying to insult you, I'm not trying to hurt your feelings or anything, but was it difficult for you to understand? And she told me yes. And so it was right before our noon conference. I had about 15 minutes prior to that, so I knew I couldn't take another patient. So I asked her, I said, would it help you if I just kind of went through it with you a little bit, broke it down? And she said, yeah. So we went page by page. I just ran through it real quick, told her what they wanted her to say, and explained to her that she had to have the whole thing filled out or they would not evaluate him. So she left. I went to conference. I came back, and by the time I came back from conference, she had already filled the whole thing out. She had taken it over there, and the only thing she didn't have was the prescription that I needed to give her. So she was back within an hour. And so, I mean, that really kind of made me feel like sometimes we just miss that mark. We sometimes miss what the reason why they don't do what we asked them to do the first time. Okay? All right, I hope I know how to work this. So I have no conflicts of interest to disclose at all. My objectives are to define health literacy and health communication, to discuss the importance of establishing a good relationship between doctors and patients and their families, to construct a stepwise plan for establishing good doctor-patient communication, and to incorporate the information provided in a practice model that focuses on the establishment of better doctor-patient relationships. So we all know that literacy is the ability to read and write, and this is important for everyday life. But that's why it's not hard to see that illiterate people actually are challenged in everyday life, including healthcare. So health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Health communication is the study and practice of communicating promotional health information, such as when we do public health campaigns, health educational information we give, and the relationship between doctor and patient. So providing pertinent health information influences the choices that patients make, thereby improving their health literacy. Good communication is a skill that is critical to safe and effective medical practice. It can and must be taught to all medical staff that actually deal with patients. Communication skills influence all of the following: how well a patient discloses pertinent information, how well they adhere to treatment plans, and how well they adapt to illnesses. And all this is very important when dealing with patients, especially even when you're dealing with patients with end-of-life decisions and bereavement. So all these things work together to provide more effective, efficient, and empathic healthcare management. In 1974, the Health Education as Society policy was introduced by Simmons, and this discussed the need for policy solutions to increase health literacy. And then in 1989, the Literacy and Health Status in Developing Countries by Gross and Offrey was the earliest study that linked the health literacy and health outcomes. So the concept of health literacy evolved from a history of defining, redefining, and quantifying the functional literacy needs of adults. But along with these changes came the recognition that sophisticated literacy skills are needed to increasingly needed to function in society, and that low literacy may actually have an effect on health and healthcare. Health literacy has individual factors and systemic factors that are part of it. And one of them, the individual factors include communication skills of laypersons and professionals, and lay and professional persons acknowledge knowledge of health topics. The systemic factors include cultural differences that actually may interfere with management, the demands of the healthcare and public health systems, and the demands of the situation in that context. Health literacy affects people's abilities to navigate through the health system, for example, including filling out complex forms like their basic health information, and actually being able to locate providers and services. It also affects their ability to share personal information, such as health history with providers. Knowing pertinent information such as their past illnesses, their immunizations, their drug allergies, medications and dosages, all these things have an effect. It also affects their ability to engage in self-care and chronic disease management, and understanding mathematical concepts that are associated with certain lifestyles. For example, when we give percentages on that are associated with certain illnesses, sometimes people find it hard to understand. It also includes the following: numeracy skills. And we all know that literacy really doesn't just involve reading. It does involve math, which is not everybody's strong point. And so some of the things that they have to focus on, some examples would be calculating cholesterol and blood sugar levels, measuring medications, and understanding nutrition labels. So, and choosing between health plans and comparing prescription drug coverage requires such things as calculating premiums, co-pays, and deductibles. So in addition to just basic literacy skills, health literacy requires knowledge of health topics. People with limited health literacy often lack knowledge or have misinformation about even the body, the human body, and the nature and cause of illnesses. So sometimes when they don't really understand, they don't really see how changing my lifestyle can actually affect my illness. And just knowing that you may have to discuss complex diseases and medications or other health information can overwhelm even persons with advanced literacy. Medical science rapidly progresses, so what people have learned in high school about just basic biology has changed so dramatically since then that it may just be totally out of their ability to understand. And then especially when you have stressful situations or just an unfamiliar situation, if you're trying to give them information about that and they're really nervous about it, they won't retain any of that information. So I found this quote by Mrs. Eleanor Roosevelt, and it said, "Understanding is a two-way street." And this quote is really good in any situation that we have in developing a relationship. You really do have to try to meet each other at some common ground in order to have a good working relationship. So I found this this chart, and it's from the AAP analysis from, it was actually done in 2010, but it was comparing information from 2004 to 2007, and it was in the National Ambulatory Medical Care Survey. And it profiles pediatric visits by source. This is just one of the charts in there, but it profiles them based on source of payment, age, physician specialty, visit type, office setting, and geographic location. And so this one shows that the majority of our initial visits, the majority of their visits occur within the first year of life. And as a matter of fact, about 52% of their first year visits are well visits, and about 46% are sick visits. So these are all perfect opportunities for us to establish good relationships from the very beginning, because we're going to monitor these kids. Most of them, we're going to follow them all the way up until their early 20s. So why are we important? As pediatricians, we are the first to actually establish a true relationship with the patient and the parent. And this relationship is usually based on consistency with frequent well visits, like I said before, throughout the first year of life. We are the parent's source of advice to prevent illnesses and injuries, and we provide early and appropriate care of acute illnesses, even to prevent their progression And we also do it in the intensive care setting. So, and we also, and the last thing I put on the slide was we guide parents in anticipating their child's needs from newborn to 21. Our patient care responsibilities are to educate our parents. And some of the things we educate them on is a good diet for our patients, healthy physical and mental exercise, hygiene, regular checkups, monitoring their physical and mental growth, and updating their immunizations. And we usually keep a good record of everything. Provided parents stay with one physician, you'll have a good record throughout their lifetime if you ever need to go back and look at something later on. I put this slide in just kind of as an example of what patients use when they come to us for advice. What are some of the things that they bring with them? They bring all these preconceived ideas that they may have received from people in their environment or even from themselves. So the example is on sun avoidance because we know that there's a higher risk of cancer with sun exposure. And so when they come to us, they have their own perspective on what they think they should do, their own experiences on what to do and what not to do, their own knowledge of maybe what they looked up somewhere, and then society's reality. You know, having a tan is beautiful, so they may feel like the more I stay in the sun, the more beautiful I am. But also what's not on this slide is the perspectives of family, friends, and even social media. So they bring all of this to us prior to coming to the visit, sometimes, not all the time. So I put a case in here just to kind of bring it home. A 2-year-old is brought to your pediatric clinic with the chief complaint of fever and ear pain. His teenage mom says he's been complaining for about a minute. We all have heard that before. How long is a minute? I don't know. He is diagnosed with acute otitis media and prescribed an antibiotic. The nurse gives mom the prescription and asks her if she has any questions. Mom says no and leaves. She's too afraid to ask anything. So the prescription is for amoxicillin, and it's written 125 per 5, 150 cc's, and it's written for 125 milligrams, TID, and we all understand what that means, but she may not. And if we didn't explain it to her, if our nurse didn't explain it to her, and if she goes to the pharmacy and they don't explain it to her, she's left to her own devices on how to figure out what to do. So in my example, she's unsure of how much to give. She decides to give her son 1 teaspoon twice a day. And when he returns for his follow-up, his ear infection is worse in my case, but it may actually be better. It may have, it may have gotten far worse than what we could have expected. But what could we have done differently? We could have actually explained to her what was going on. We could have had our nurse explain, and not just depend on other people. We can kind of start the ball rolling ourselves and then allow other people to reinforce what we've already said. And Jessica and I came up with this name, just kind of trying to be funny. His name is Breaking. And so also what we have to take into consideration is at home, we don't know what they have to use if we don't help them. And I apologize, it's kind of blurry. My PowerPoint skills are not that great, but please forgive me. So she could have a spoon, she could have a measuring spoon, a syringe, a dropper, she could have a cup. We don't know what she has at the house. So I found a study, and it's a small study. It was done in 1997 at the Maricopa Medical Center in Phoenix, Arizona. And in this study, their objective was to determine if education can decrease parental dosing errors. They used 90 patients, Spanish and English speaking, and they got their patients from the medical center and from some pediatric offices in the area. They divided them into 3 study groups. Group 1 was given a prescription and verbal instructions. Group 2 received the prescription, a syringe, and the correct dose demonstrated. And group 3 was given a prescription, the syringe with the line marked exactly where we wanted him to, the correct dose, and a demonstration. The parents went to the pharmacy, filled their prescription, and came back and demonstrated drawing up the medication under observation. So group 1 had a 30% chance of actually getting it right. 83% filled the medication appropriately, and 100% of the third group gave the prescription, drew up the medicine correctly. And so their conclusion was that education can decrease medication errors in their patient population, and so it does make a difference. This was another study that was done this year, and this was done at the University of Tennessee Health Sciences Center at the dental office, the dental school, and 3 private dental offices. They had 120 parent-child pairs in their group, and these were kids that had a dental procedure and were prescribed just an over-the-counter pain medication. The parents did a survey, and they did a liquid measuring exercise. They wanted the parents to, they instructed them how to measure 5 mLs of liquid using a medicine cup with clear markings, medicine cup with printed markings, a cylindrical measuring spoon, and also an oral syringe. The groups that got the printed markings, they divided them into 2. Though some of them received text-only instructions and some received text pictogram instructions. So of the 120 participants, they showed that there was a significant difference in their ability to measure accurate doses, no matter what device they used. But they found that the medicine cup was the one that had the highest frequency of errors in it. And ironically, I think the measuring spoon, the spoon had the best results. And so their conclusion also was that they needed to educate their patients more on even the medication dosing on over-the-counter medicines. So I put a quote in here. It says, to effectively communicate, we must realize that we are all different in the way we perceive the world and use this understanding as a guide to our communication with others. So let's switch gears and talk about doctor-patient communication and how we can bridge the gap between doctors and patients and improve our communication skills. Effective doctor-patient communication is a central clinical function in building a good doctor-patient relationship. And this is the heart and art of medicine. It's important in the delivery of high-quality care. A doctor's communication and interpersonal skills are essential in order to diagnose and manage patients. It's essential in establishing a caring relationship with the parents. These are basically the clinical cores which are essential for effective delivery of good communication and good relationships with our patients. So with that being said, there are 3 purposes for effective communication, and they are to create a good interpersonal relationship, exchanging information, and making treatment-related decisions. Because understand, we're trying to establish this relationship, and we're going to probably see these kids from birth to 21 is what some people do. And so we really need to start off with a good relationship from the beginning so that they trust us and understand that we have their kids' best interests at heart. Some physicians at the University of North Carolina School of Medicine, they found that there are several techniques that can help physicians facilitate an effective patient interview and make the most of the time allotted during their visits. The steps include active listening, nonverbal communication, agendas, empathy, educating patients, reassurance, agreeing on a treatment plan, taking responsibility, avoiding overreacting, and establishing boundaries. So for the active listening, we are to encourage the patients to tell his or her story and then ask open-ended questions and then restate exactly what they said in their own words. And we also have to have effective use of nonverbal communication, which can help us develop an environment of support, comfort, trust, and security. Frequent eye contact and periods of well-timed silence are examples of methods that can actually enhance our interview. Now, understand that we all come to appointments with different agendas. Our agenda is to actually help the patient understand the diagnosis and the treatment plan and to get them on board with their treatment plan and to be more proactive. But the patient may actually come with a different agenda. They may come with they might come trying to see if there's another diagnosis or a cure or even reassurance that nothing's wrong. So we have to make sure that we are very vocal about what our plan is and what their plan is. And we have to be able to empathize. We have to acknowledge that there are difficulties that they may be experiencing and resuming their lives. If they have a major illness, then we have to understand that they still have to function in the world. They have to still live, be a part of their family, go to work, just the normal daily activities. So we have to remember that. And we also have to acknowledge the difficulties in dealing with major psychosocial loss or trauma. They may deal with it a whole lot differently than I would. I would cry. First thing I'm gonna do is cry. Some people get mad, so we have to understand that there are different ways to handle different situations. And also we have to understand that it's important for us to validate their feelings without making a personal judgment or offering a quick solution. So educating our patients, this is a crucial part in our relationship with them. It involves a good dialogue with a good medical interview, and provides new information consistent with the patient's needs and interests. So we have to make sure that they are well informed to the best of their understanding. You know, don't try to talk over their head or anything. And if sometimes we have to provide written material, sometimes that may help them better than what we can say. Maybe we can just give them the gist of the information, but give them something to take home and they can read it in their leisure and process it better. And by reassuring them, the doctor helps to comfort them by identifying and legitimizing their concerns. And we also don't want to worry, and recognizing their emotions. So after the medical interview and the physical exam are complete, it's important for us with our patients to agree upon a treatment plan. And we should take into account the patient's personal experiences and their lifestyle, like I said before, and provide choices that are consistent with these factors. It's also important to have the patient acknowledge that they have a role in managing their illness too. We can only do so much. We can discuss it, we can explain to them what the plan is, but they have to assume a responsibility in making sure that they do take care of themselves as best as they can. And we should ask the appropriate questions to help shift their management to the patient. You know, we should ask, like, so what do you understand about what's going on? How is this illness affecting you personally at home when you're not around us in the office and stuff? Also, we have to understand, like I said before, that patients can be demanding when they receive bad information or a bad diagnosis. We don't know, they may process it differently from us, like I said before. So it's really important that we remain calm with dealing with them. If they become hostile, then we just kind of step away and don't, you know, engage them in any way. And establish limitations for them. Make sure that they understand that, you know, we're here for them, but we're not here. You can't move in with me and, you know, I'm not going to take care of you. You have to do some things on your own. And we address feelings and emotions honestly to avoid any conflict. We also help patients to recognize their perspective on the shared responsibility. And like I said, avoid setting boundaries that will make them feel bad or belittle them. And when we schedule follow-up appointments with them, we make sure that we do it as needed to accommodate them. Sometimes they really do need that second appointment just to kind of come to grips with it or actually wrap their brain around it, is what I always say. So communication is a skill that you can learn. It's like riding a bicycle or typing. If you're willing to work at it, you can rapidly improve the quality of every part of your life. And that's the good part of it. That's what we should do. We should understand. The cartoon at the bottom is what we shouldn't do. It says we like to start out being very involved with you, but eventually be drawn away to much more interesting cases on Twitter. So this is something I got from Dr. Terry Davis. It was in one of her articles that she wrote. It was in the role of health literacy and patient-physician communication. And in it, they did a lot of research on different methods that worked for improving physician-patient communication. And so they came up with 6 steps to enhance the understanding. And one of them was to slow down and take time to assess patients' health literacy skills. Find out what is their level of understanding. Use living room language instead of medical terminology. Don't use such big words. We may have to break it down. We may not be able to say topical. We may have to say rub it on your skin. You know, it may be just that simple. Show or draw pictures to enhance understanding and subsequent recall. We have limit their information given at each interaction and repeat instructions if needed. And use a teach-back method or a show-me approach to confirm understanding. So after we've explained everything to them and we say you understand, most of them will say, oh yeah, I understand. You say, okay, well what did I just say? And so they'll say, okay, tell it to me one more time. So I was like, okay, I know you didn't get it. So. And then be respectful, caring, and sensitive, thereby empowering patients to participate in their own health care. Whatever words we utter should be chosen with care, for people will hear them and be influenced by them for good or ill. And it's from Buddha. And I found a cute baby Buddha picture. So let's talk about a program that takes the patient's point of view and perspective. This is the Consumer Assessment of Health Care Providers and Systems. And it's a survey And it was actually started in 1995 in October, and it was initially done by, prior to 1995, it was done by individual healthcare plans. They would come up with a survey, send it to all of their patients, their enrollees, and ask them, how well do you feel about this? Or, you know, just ask them questions about the health plan in order for them to improve their plan. But in 1995, the Agency for Healthcare Research and Quality came up with this universal survey that could be used by everyone, and it could be compared between health plans. And it eventually started including physicians and how patients feel about coming to us, how they feel about their level of care. And so this is something that's done every year, but you can actually compile the information over an expanded amount of time if you want to. It focuses on identifying and confirming issues that are important to healthcare consumers and influence their decisions. Initially, the goals were, in the first CHPS survey, the goals were to develop just a standardized patient questionnaire that could be used by different sponsors and over time, like I said before. And it was also used to generate tools and resources that could help sponsors produce understandable and usable information in order for their consumers to understand. But with the updates, they've modified it a lot, and this is the third update that they've done. And so their goals now are to develop and test ways that organizations can use this survey, the data, for quality improvement, to develop reporting methods to support both consumer choice and quality improvement in healthcare organizations, to continue to develop and refine the surveys, and also to support dissemination and promote the use of the products. And so there's also patient satisfaction surveys that are out there, and they're comparative. They both include ratings of health plans and providers, but the CHPS, this one takes it a little bit further. They ask patients to report on their experiences with healthcare services, not just write a number. They can actually explain in detail whether it was a good experience or not. And then these reports about care are regarded as more specific, actionable, understandable, and objective, rather than just doing a general ratings. So these are all of the different surveys that you can, the different sections within the survey that you can look at. And so the one that I focused more on was the clinician and group, because that's the one that affects us. This is the one that we can actually go on, have our patients fill out this survey, and they can tell us how well we're doing. So the clinician and group surveys, they ask patients about their recent experiences with clinicians and their staff. It's a standardized questionnaire, and it's optional and you can actually add extra information to it specific to your patient population. There are different versions available. There's a 12-month survey, an expandable 12-month survey with the patient-centered medical home items included, a visit survey, and then there's you can get instructions on how to use this data, how you can actually read it, and on how to set it up on your own. And so there are different downloads that, like I said before, that you can get, and they include questionnaires for adults and children in an outpatient setting, and also in a hospital setting. And then there's supplemental items, like I said, that you can add to your questionnaire to make it more individualized for you. And then there's guidance on administering the survey and preparing the data for analysis. And then there's SAS is their program that they use, and the instructions for analyzing the results. You can also use this as you can receive guidance on reporting the survey results that you may have to this group, and then you can compare your data to other groups too. So this is the 12-month survey that they have, and you can go on their website and you can click on all this and just pull all the information up, and you can actually download the complete survey and then, like I said, administer it in your office. And so in the 12-month survey, what they're trying to do is get timely appointments. They're trying to ask the patients what is their opinion on whether or not they received these, and how well was the visit, how well was the information. So they ask them about getting timely appointments, care, and information, how well the providers or doctors communicated with them, how helpful and courteous and respectful your office staff was, ratings of the provider himself, how much attention did the physician pay to your child's growth and development, and did you get any advice on how to keep your child safe and healthy? Excuse the visit survey includes everything that's in the 12-month survey, but everything is specific to that visit. And they also ask whether you would recommend the provider, the time since your most recent visit, and wait time at your most recent visit. And so the results submitted by this survey around the country, they use this the database to compile compile a big database, and allow, like I said, you and other groups to see how you compare. And what the reports do, they assess your overall performance of different kinds of physician practices and groups. And they analyze the performance of a single physician or group relative to appropriate benchmarks. And they improve patients' experiences with doctors' offices. The results can be used, like I said, to identify opportunities for improvement, to track progress towards your goals, and they can be shared with all parties involved. And so I found an article, it was entitled, "A Clinical Communication Strategy to Enhance Effectiveness and the CHPS Scores." And the authors devised this alert model. And like I said, it was developed from the survey. They ascertained the patient's impression of how how well the physician communicated with them. They also assessed how well the physician listened to them, how often he explained things to their level of understanding, and how often the physician showed respect for what the patient said, and did he spend enough time with you. So ALERT stands for always, listen carefully, explain things understandably, respect what the patient says, and time management perception. And for always, I mean always be consistent. Always, if you do the same exam for everyone, then you won't you won't miss anything. You'll get used to it, and then you'll be able, the first couple of times may take a little bit longer than the rest, but if you have a good model, you'll be able to move through it quicker, and the patient won't feel like you're actually rushing. They'll feel like you're actually sitting here and you really are paying attention to me. When we say listen carefully, we talk about active listening, which is one of the key ways in which we take in clinical information, and it's done by maintaining good eye contact while the patient is speaking. Other things we can do is sit down, come to their eye level, lean in, keep an open and receptive body posture, and use reflective statements. And never appear rushed or hurried. And don't just look at your watch and say, I need to move on to the next person. Make them feel like you're the only person I have to deal with. Even though I have 10 minutes, you're going to be the only person for these 10 minutes. So this is another cartoon. It says, you can see the doctor now, just don't ask him anything too medical. When we're explaining things, avoid using medical jargons and abbreviations, and explore barriers to compliance. Why are you not being more compliant? Is it because things cost too much? Travel, the work schedule is crazy. Try to find out what's going on. Provide resources if you can, handouts, diagrams, draw a picture if you have to just kind of better help them understand what's going on. And check for understanding, like I said, the teach-back method. Try to see if they really are comprehending what you're saying, and if they are in agreement. You may have had this whole talk about what's going on with what your plan is, and they may not even want to do any of that. You really need to stop smoking. Well, I'm not. So you just have to kind of deal with that too. And then ask them if they have any additional questions or areas that you need to go back over. The doctor will see you now. Here's your medical jargon dictionary. And the fourth one is respect what the patient says. Ask for their ideas about his or her illness. Ask them, what do you think might be going on? What worries you the most about this? Elicit specific requests from the patient. You might ask them, how might you and I work together to make this easier for you? And then explore the impact it has on their lives. Tell me, you can say, how is this affecting your ability to work? Or deal with your other children, because we deal with pediatrics. So you may have to one child may require more attention than the other ones. You have to ask them, how are you helping the other kids deal with this situation? Or for an example with me, when I have a newborn baby, I always ask mom, if you got other kids in the house, how are you dealing with them? Are you spending time with those kids outside of with the baby? I know you've just had a baby and you need to rest, and do you have someone else that can help you take care of them? And also when dealing with the husband, if you guys are together, there was a reason you guys got together to have this baby in the first place. Don't forget that relationship too. So I try to, talk to them about other aspects of their life also. And the last one is time management perception. Focus on demonstrating empathy, concern, and understanding. Like I said, use open-ended questions. Avoid rapid fire or closed-ended questions, because they can make you seem like you're rushing through. And then if you have a delay for whatever reason, either you or your staff can just let them know the reason, we're behind is because of whatever. So now that we know the importance of good communication with our patients, we should also understand the results of poor doctor-patient communication. And some of the things that can happen if you don't develop a good relationship, you can have an increased malpractice risk, poorly compliant patients. You and your patient can be dissatisfied because you're not on the same page, and then poor patient health outcomes. And so I found this article. It was called The Communication Gaffes, which is a root cause of malpractice claims, and it was written by some lawyers that deal with malpractice, and they said that the root cause is a breakdown in communication between physicians and patients. And they looked through their depositions, and they saw that 71% of plaintiff depositions were the result of a problem with the patient-physician relationship, and that most litigious patients perceive that their physicians are uncaring. Most of the reasons for malpractice claims were because we just don't listen. We're not listening well. The delegation of critical consent communication. We may allow someone else to try to explain, leave it to someone else to explain it to the patient. Failure to share information timely. Failure to have meaningful, empathetic conversations when adverse outcomes occur. And just defensive behavior when the patients seek to learn more by questioning our diagnosis and treatment options. So I found this pie graph, and it showed that the 35% of the causes for malpractice claims is communication. That's the main thing. So this is the area that we really can focus on, and some of the other ones we can too, but I mean, this would decrease a lot of the malpractice claims that are out there. So this slide is a little difficult to understand, but I thought this was a good example of a good communication. It says, actually, I'm not a doctor, I'm the healthcare administrator. He said, that's okay, I'm not the patient, I'm his attorney. So, in conclusion, doctor-patient communication is a major component of the process of healthcare. Effective doctor-patient communication can be a source of motivation, incentive, reassurance, and support. And a good doctor-patient relationship can do the following. It can increase job satisfaction, it can reinforce patient self-confidence, and also reinforce a patient's positive view of their health status. We have to remember in a pediatric, as pediatricians, parents are the key partners in our relationship with our patients. Doctors with better communication and interpersonal skills are able to detect problems earlier, and developing a strong relationship with your patients can lead to a more successful quality of care. And last but not least, patients appreciate a physician that is friendly, supportive, and treats them with warmth, humanity, and respect. And that's it. Any questions?
Very nice.
Thank you.
Any questions for Pam?
It was just that good.
It was terrific. And I mean, you covered so many things that I think that we can all improve on. One of the things you're talking about, I know they did a study as far as patients' perception of how much time you spend in the room.
Right.
And those physicians who sat down, they did a study where the doctor stood up and talked to the patient, and then a study where they sat down and talked to the patient, spent the exact same amount of time, but the patient's perception of how long they were in the room was that they were in the room much longer time if they sat down. Mm-hmm. The other thing, when you're talking about prescriptions, Epic does a lot of things well, but one of the things that it does, it's nice that it calculates a lot of times, right. But frequently if you put in 90 milligrams per kilogram, it'll spit out that the patient needs 9.7 mLs. Well, when our patients have a hard enough time doing 10 or 9, or it's helpful to tweak that so that it is
Kelsey's working on that.
Yeah,
Because I mean, she actually showed us some scripts that print out 3.125 mils.
Right.
And
So, you know, one of the other things is that it's important for us to understand some of the language that our patients use as well. And because I specifically remember a patient that was talking about, it was a newborn, and she was talking about there was a pulse, there was pulse around the umbilicus, and she was talking about pus.
Yeah.
And so, you know, there may be some pulsation there, but that's not what she was talking about, and it was an infection. And so it's important for us to if something doesn't seem to make sense, you know, do we need to investigate?
And you can ask them to show me what you're talking about. You know, describe it in whatever words you need. You may think the word is offensive, but at least we both understand what you're talking about.
As far as getting a nutrition history, I don't even ask the parents, how are you feeding your baby? I tell them, get out your diaper bag, take the stuff out, and show me how you do it.
Right.
Because they know the right words.
Right.
They know the right words, but that doesn't mean they're doing it.
Right. And a lot of times sometimes you'll have patients that they know when they've had a surgery or when, you know, what type of procedure. They can describe it, they just can't tell you, oh, she had a laparoscopic cholecystectomy, but she, you know, they can tell you they had a surgery and the gallbladder was removed. I mean, I know that's basic, but yeah. So.
And as we're getting more and more non-English speaking patients, it's important to remember too that here we're fortunate in having the language line that we can use, so we have medically trained interpreters who can ask the patients questions and then relay the answers back to us. If you run the risk of getting inaccurate information if you use a family member or friend who is there with the patient, either getting inaccurate or false information back from the patient to you, or them relaying your information incorrectly to the patient. So you have to be careful about that, and particularly when you're discussing sensitive issues with the patients, you definitely want to take advantage of the language line rather than use a family member or friend as an interpreter.
I think so. We have an advantage as being as pediatricians because I think that when we deal with parents, for the most part, the large percentage of parents want to do is the right thing for their child or their children. And so in interviewing them and communicating with them, we have probably the best of both worlds when we think about adults, when we have to talk with them and get a history. So I think when we start dealing with them, we should go in with a positive attitude that this parent really wants to help their child. They want to communicate with me, so what can I do to make this easier? So rather than thinking negative, like they don't care about their child or they don't want to do this, they don't want to do it, think positive. They want to be here, so let's see how I can communicate with them. And I think that the majority, like I said, they want to communicate with you. So being kind and considerate and trying to think about maybe what they have to deal with, trying to walk in their shoes is very important.
Yeah.
And I think that, you know, most of them will begin to feel comfortable with you. You're establishing a rapport with them. And so that's really the best way to get a history, to establish rapport by letting them know that you care about their problem. And most of the time they'll talk more than you want them to talk. We have to say, okay, let's stop, let's turn it off. So I think that's a very important thing to be able to do, but just letting the parents know that, you know, I'm concerned about your child, I'm concerned about you, and let's see how we can work together, because it has to be a team approach. You may be the physician or the whatever provider you are, but that parent, you need that parent's help in caring for their child to get the answers to the questions to the puzzle you're trying to solve. You're like a detective. And so when both of you work together, you get the best result. So I just think that we should all always consider or remember that in trying to take care of a patient, that we're going to work together as a team, because I can't do it all together. Just like as we work here with the nurses, the respiratory therapists, we have to be a team working together, communicating. Communication is key for us to get any good result.
And also when you're dealing with parents that come in and they're angry or mad, they may not necessarily be mad at you. They may start snapping, but she might have just had a hard time bringing 4 kids in here. You know, I have a bunch of kids. And God, just trying to manage them is tough. And, you know, my children are, I think they're the best in the world, but somebody else may not think that, you know, and that's frustrating, especially when you're trying to deal with carrying a car seat and you got 2 more pulling behind you. That's tough. So
you have to ask them, why are you mad? What happened?
Yeah.
You know, tell me about why you're so upset. And sometimes they'll open up and it has nothing to do with what happened in the clinic, and they'll tell you something that surprises you about their life or whatever, gives you an idea of what's really going on for them.
Or shocks you.
I mean, Sunday night I sat and talked to a mom in the ER. She brought in her 8-day-old baby because she was making funny noises. Well, she's making normal baby snorting, weird breathing noises, whatever. And I'm like, they're normal noises, and tears started rolling down her cheek. And I'm like, what is going on?
Yeah.
Who's helping you? Because she was really young. It was her first baby. She and baby's daddy have a house by themselves, but he wants to stay at his mom's house. She wants to take over and raise the baby. She's saying that everything mom's doing is wrong. She's young and she's got an 8-day-old.
Yeah.
And hormones and not sleeping. She doesn't need anybody telling her she's not doing a good job. She is. The baby looked great.
Yeah.
But I spent 20 minutes in the room and I felt much better about it than just, oh, everything's fine, and walk out.
Mm-hmm. And that's what she needed.
Is there one other question?
I was just piggybacking off of what Sarah said. I mean, sometimes you have patients who do come in angry and they might start raising their voices at you. I know somebody was in clinic when I had this patient that was like raising her voice, and I'm like, look, I'm trying to help you. So when I said, that, then she like calmed down. I was like, we need to both do what we can do to try to figure out what's going on. And then all of a sudden we were like best friends, and she was telling me her, husband actually left her during the pregnancy with this other lady, and she was making more money, and so he left. I mean, so it's like a whole bunch going on. I mean, so being able to like identify with them makes a big difference, because then they really do think that you care, as opposed to being like, well, whatever, I'm just gonna leave. Because sometimes some people can't do that, and you don't want to do that to them because you don't know what's going on in their lives. And a lot of times people have preconceived notions, or we be judgmental, and I think it's important that we don't, because a lot of these people have a lot of stuff going on. So,
you know, I had a case in the clinic, and the chief complaint was just medicine refill. And I walked in and was talking to this mom. It was a 6-year-old, she had a 2-year-old, and she had a brand new baby, a 3-month-old. And so in the room, we talked about he had ADHD, and she said, but he has all these other things too that he keeps asking me about, and I just don't want to talk to him about. And I was like, well, what is it? And she said, he keeps wanting to ask me about some guy. She said, is he going to come back and he's going to get me again? And I'm like, well, she said, but I just can't talk to him about it. And so I immediately started getting mad. I'm like, he should be able to talk to you about anything. And so I left out. And just so happened, Dr. Farrell was there that day, and she was my attending. We went back in the room, and so she, sat down and did the perfect interview with this mom, and was asking her, so, what is he saying? And she said, apparently mom had the 2-year-old's father had molested this kid, and then her boyfriend after that had physically abused him really bad. And so both of them were in jail, but he was so afraid, thinking that they were gonna come back later on. And then mom was already in another relationship. The 3-month-old's daddy was all kind of drama. Anyway, so she said, yeah, he keeps wanting to ask me, is he coming back? She said, but I can't talk to him about that. And so she immediately folded her arms and became defensive. And so I'm sitting there like, you have to talk to him. And so Dr. Farrell said, well, why is it that you don't want to, you feel like you can't talk to him? She said, because it reminded her of what she had gone through. And she had been severely abused as a child, and it never dealt with. And so she was in order to help him deal with his, was going to have to bring all her feelings to surface, and she wasn't ready to handle it. And so we actually wound up referring her and the kid to psych, so. that set me back a couple days. I still think about it just because it had that much of an impact on me.
So what else is going on? Show me. Why are you so angry? What exactly do you want me to do? All of those are really good statements and questions. And it'll get you a whole lot further than just, oh, I can't deal with you, and your kid's fine, and walk out the door.
Right.
Yeah, and so I think Pam's given you a very nice presentation of the key things that you need to do to establish communication. And really, when you do that, you're paying attention, so you can pick up these nuances that lead you to really understand why the patient's there, what the other issues are. And I think one of the things I always talk about, it's very easy often to make a diagnosis, but it's much more difficult to establish the therapeutic relationship that you need with the family and the child to really manage an illness. And so I think that that's really your goal, is to develop those communication skills so that you could really develop that relationship with the parent, the relationship with the child, to be able to do the best you can for that family. And I think these are the principles, and actually she even gave you some ways that you could test yourself to see how well you're doing, and I think those are all good things. So thank you, Pam. Thank you, Don.